So, welcome to Medical Safe. My name is Tanvir and this is my colleague David, and we are going to talk about an exciting exploratory project we are doing, which is towards building automated radiology and cardiology assistants of the future. You can think of them as next generation cognitive computing systems that bring textual and image understanding to the next level, and developing tools for clinicians and helping them in their clinical decision making. So clinicians, particularly radiologists, have to look at lots of images a day. A screen like this is their daily things that they watch, and as many as an emergency room radiologist, for example, may see as many as 200 patients a day. And if you think of a patient's data being about 250 gigabytes of imaging, we are talking about petabytes of data in a large hospital setting, making their storage and analysis both a big data problem from computing standpoint as well as from storage and analysis standpoints. So, as I said, a typical emergency room radiologist may look at lots of images. So, in this particular case, a lower body CT angiography may have as many as 3,000 images per study. And in this particular case, we are looking at a lower body CT scan, and many of these images look very much alike. So, what is important to a radiologist may be only a handful of these images, and they have to sift through such large collections to actually zoom on to the problem, and as a result they suffer eye fatigue, and much of their clinical decision making is guided by images alone, without looking at the holistic clinical data that they may have in their electronic health record systems, but they simply don't have the time to navigate. This is also true for cardiologists, who again look at images. In the case in here we are seeing an echocardiographic study where they may be looking at several views of the heart from different viewpoints using an echocardiographic scan, and in this particular case they are studying a patient with mitral valve prolapse, and they would have to examine several of these images to see which of these sequences actually shows evidence for mitral valve prolapse. Now, such analysis is very image intensive, and as I said, requires them to focus on and examine and browse lots of images, causing them eye fatigue, and as many as 36% of them have suffered eye fatigue and often have to retire early. Moreover, since they are only looking at imaging and they don't have simply the time to assimilate all the clinical information about the patient, they often end up in diagnosis errors. As much as 30% error rate coded for diagnosis in these cases. So, what we are working on is building the next generation clinical informatics systems that bring together holistic information about the patient. So, for example, in this case we are showing 16 years worth of clinical history of a patient, showing what are the dominant problems, what medications they have been on, as well as comparisons to similar patients that show patients who are similar to your current patient, what diagnosis they've had, what treatments they have undergone, and what outcomes they've had. In addition, the imaging studies are right there along with the rest of the clinical information. So, they can then go to one of these studies and do an examination as they are often accustomed to. So, in this particular case, let's say that is an angiography study, and typically an angiography study consists of over 5,000 images, and they are organized into something called runs. And in this particular case, what we have done is pre-analyze this data and filtered and retain only those that are most important for a clinician to see in a storyboard of about top 20 images. Starting from these, you can actually go back to the raw angiography study, such as starting from here, you can go to a run and then watch the anomaly that they are trying to zoom on to. This particular angiography shows a case where there is stenosis in the coronary arteries, and as you can see, they are able to annotate that and analyze as they have access to the entire data as well. But our analysis has gone from 5,000 images to almost 95% reduction in the data, and only focusing them on the top 20 images that are important for them to take a look at. So clearly, in order to do this, it's not just a question of filtering the data and just removing or subsampling it. We have to do it in a very careful fashion. We have to make sure that these images are indeed the most representative ones and have not missed anything from the point of view of diagnosis. So in order to be able to do that, machines have to develop very advanced analysis capabilities. They would, for example, in this case, there is showing a raw angiography image, which is showing stenosis in the middle called the ramus artery. And in order to recognize that that is indeed an interesting image to show, because there is a stenosis present there, the machine itself would have to analyze and recognize the stenosis. In order to recognize the stenosis, it has to know what some understanding of the coronary anatomy and also what normal and abnormal appearances look like. So there may be reference models stored for different appearances of coronary arteries that show the anatomy. But as you can see, the references are not looking quite like your new image. So there is quite a bit of matching problems that need to be solved between these two. So the first step in doing this analysis is to extract the coronary arteries themselves from images, and this by itself can be a very hard problem in image processing, because the intensity distributions within the artery and outside in the rest of the background are roughly similar. So it's very difficult to separate the two. So as you can see, we have done an analysis through specialized filtering mechanisms using something called radon-like features. We are able to highlight the coronary arteries, and then we are able to use a special adaptive thresholding technique to extract the coronary arteries from the background. We're able to then skeletonize and extract salient junctions and coronary artery segments. So at that point, we now have some description of the coronary arteries. We don't yet know what arteries we're talking about, what segments, but that's when we go back to the reference models, where we have their description stored and annotated by clinicians. So at this point, it's a question of matching your current coronary artery layout to a reference model layout. And this matching problem can also be a very difficult problem, because coronary arteries are flexible objects, if you will. They are articulated, all right, because they are held at junctions, but then within the junctions, the arteries can move quite flexibly. So to model such transformations between a given reference and a current object artery instance you're seeing requires us to develop complex non-rigid articulated models. So if you did a straightforward registration, you would get an error such as this, where you can see there's quite a bit of mismatch between the reference model and the artery. But what we've come up with a constrained articulated non-rigid transform that does the alignment better bit by bit in terms of individual artery segments, and accounts for their order of appearance around the junctions through something called the curve context. And that allows us to better align them. And as you can see in the next image, after registration, they're much better aligned. Now, at this point, we know what the label in each of these arteries are. So then we are able to zoom into different artery segments and then track them over the heart cycle, because each run shows several heart cycles. So you'll then be able to note that there is a thinning of the arteries in some of these sections that has persisted across time. This persistence is actually captured in a spatiotemporal surface that we plot of arterial widths over time, and then pick minima of these surfaces to correspond to salient stenosis, and that's how we are able to detect a stenosis. Once we detect a stenosis, we say this is an important image, and let's flag it, and let's give it back to the clinician to see, to do further examination. So in order to do this, we obviously need quite a bit of training in the specialty, and therefore we work with clinicians, cardiologists, radiologists, and across various modalities and specialties, and we bring together researchers in machine learning, pattern recognition, medical imaging, and computer vision together with these clinicians to come up with new techniques and methodologies for extracting clinical information that is meaningful for clinicians to view at. And this is indeed possible because we have a large research cross lab research project consisting of many team members across the globe. So Over the years, IBM, as you know, has been producing many different products and solutions in healthcare, and you've already been familiar with Watson solutions. This would constitute the next generation advancements with giving imaging presence to Watson-like solutions, and we hope that these such assistants will be employed with clinicians, not just in large scale hospitals, but also in smaller diagnostic settings, and hoping to alleviate their viewing burdens, as well as giving them access to holistic clinical information about the patient that helps in the clinical decision making.